All right, welcome to today's lesson in anatomy for massage therapists. We're going to be discussing the upper limb. As you can see in front of you, this is the upper limb on the right side. We are going to to remind you guys, we're going to be moving from deep to superficial and then proximal to distal. So we will do the deep things first. We'll cover the bones, we'll get into the joints and ligaments, and then we'll get into the muscles, we'll get into movements, nerves, as well as any medical conditions as we move through this lesson. All right, so I'm going to give props to my my program that I'm using. This is the Complete Anatomy. It's from 3D4 Medical. You should have gotten information on this in the introductory video. So if you didn't, then let me know and I'll tell you all about it. But I'll brag about this program throughout the entire videos just because I love it and it's amazing. And every time I get on it, I learn something new. Just like with every video that I've done so far for this course. All right, so we're going to be discussing upper limb today. And we're going to start up here with the clavicle. So the clavicle is very interesting. It's very small muscle. This is also known as the collarbone, but I want you to kind of notate or kind of notice how much space is here in between the clavicle and the sternum. This actually allows for a little bit, for quite a bit of movement because it does have so much space. It can really move. This is the only joint that connects the arm to the torso. Everything else is muscular. There's no other joint that combines the arm and the torso, which gives the arm so much more movement, but can put so much more stress on the muscles that surround it, especially with any type of injury to this area. My sister broke her clavicle when she was little, and she had to wear this really weird brace thing. She still has a little bump on her clavicle almost 3 decades later. So this area can really wreak havoc on a person's body. My sister, her posture does need a little bit of help, but because of the injury that she did have, it's a little bit more painful for her to receive the work up in the pec and trap area because of that. So this is a fairly important bone. But it's also, this bone also gives us a way to kind of look at the body and see what's going on, even if there's not been an obvious injury. So when we're looking at this particular model, if you look here, we're in anatomical position. And so very few people lay on the massage table in anatomical position. And I have yet to meet anybody who walks around in anatomical position. Structural position and anatomical position are actually two different things. Structural position is the palms are at the sides of the body. But even if this palm is at the sides of the body, you'll start to notice things rotate. We'll discuss this once we get into like the shoulder joint and things like that. So with the clavicle, I'm reaching out for my trusty pen here. With this clavicle, let's move to red. There you go. The clavicle should be almost horizontal, but a lot of times you'll see people with the clavicle at a much higher angle. And this actually tells us as body workers that muscles in this area are really affected. Now, we're going to get into those a little bit closer to when we're dealing with neck and things like that. So, but I want to kind of put that little earwig in because once you get to the neck section, we're going to be discussing this yet again. So we have the clavicle. The next bone that we have, I'm going to zoom in just a little bit more. I'm going to creep in here. All right, we have this beautiful bone called the scapula. So the scapula, we have medial margin here, we have the lateral margin here, inferior angle, superior angle, Infraspinous fossa, infraspinous is down here. Supraspinous is up here. I'm getting ahead of myself. We have the subscapular fossa on the anterior side. All of our rotator cuff muscles are going to be located on this bone, which makes it really, really important for the shoulder. So if you deal with any type of frozen shoulder, rotator cuff injury, anything like that, these muscles are the ones that that you really need to make sure you understand when it comes to doing stuff like injury massage. On this front side, we have the coracoid process right here. You're going to see me refer to this quite a few times. And I want you to kind of note that, like, if you see, there's not very much space in between here and here. We'll have a bursa in here that will protect it, but there's not that much space. So a lot of times when we're dealing with things like an AC injury, you'll see this. So here's the AC joint right in here. If the AC joint is injured, you'll notice that that scapula may move up, the clavicle may move down, and it hits these bones. And that really is not pleasant to have that bone-on-bone feeling. And then the last bony landmark of the scapula I want to notate is going to be here. It's in white. It is the glenoid cavity. Excuse me. I almost told you guys the joint. It's the glenoid cavity. And this is the socket for the ball and socket. And there's different ligaments and muscles that will attach around here. All right, so the next bone that we have, we're going to zoom out for a sec, and we're going to look at this beautiful bone. It is the humerus. So the humeral bone, this is going to be the one that is in the upper arm. Okay, some things I want to notate, and we're going to do this, and we're going to move here, and we're going to come in here. That's where I want it. Okay, so things I want to note here is I want to note some bony landmarks. Here you have the greater tuberosity, or the tubercle, and here you have the lesser tubercle. And so all of the rotator cuff muscles will attach to these bony landmarks. You also have this valley here. This is called the intertubercular groove. Inside this groove, you have three muscles, the latissimus dorsi, the pec major, and the teres major, all attach into this intertubercular groove muscle, or into this intertubercular groove landmark, as well as you will see when we start adding ligaments in that we have the biceps tendon and the tendon sheath that goes through it. So very important to kind of see how that relationship works. It's probably one of my more fun it's one of the more fun parts to get into when we start talking about the ligaments and stuff like that. All right, so now we're going to move down into, we do have the elbow here. You have the medial, if you look at the humerus, you have the medial epicondyle here, which sticks out more. Lateral epicondyle. Lateral epicondyle is for golfer's elbow. Medial epicondylitis, so inflammation of the medial epicondyle, is associated with tennis elbow. We'll discuss those a little bit in greater detail, especially if you are watching this in conjunction with my injury class. We're going to be discussing how to address both golfers and tennis elbow in that class. We have the ulna here, which is going to go down to the pinky finger. The radius is going to go down to the thumb, and that is this green one here. And then the last thing in bones that we're going to discuss is going to be the hand. So we have our carpal bones, and the carpal bones are here. There's 8 of them. And then we have metacarpals. We have 5 of those. And then we have 14 phalange bones. Did I just say metacarpal muscles? Anyway, metacarpal bones. There's 5 metacarpal bones. And then we have 14 metacarpal, or 14 phalanges. There's 2 in the thumb and then 3 in each one of the fingers. All right, we're going to hit undo on all of that. There you go. Now, there's one thing that I want to point out. Because this is now sometimes this doesn't go the way I plan it to. Okay, A little bit better. All right. So when we're talking about carpal bones, a lot of times you'll hear clients talking about carpal tunnel syndrome. And so what we have here is we have the floor of that carpal tunnel. So in through, like we have our trapezium here, we have the hamate, little horn of the hamate bone here. And what we have is we have a piece of connective tissue. That's a ligament. It's called a retinaculum that covers here. We're going to talk about this when we come back to the wrist. But I want to kind of notate where on the bones you see that. So you kind of create this tunnel here. Then off here to the side, let's use pink. Off here to this side here, you also have a little tunnel that is created by ligaments. And so you have the Guyon's canal, which is over here, going down towards the pinky, because this is the pinky here. This is the thumb over here. So you have this little Guyon's canal, and you'll have another nerve that goes through it that innervates the pinky. So if you have somebody with like thoracic outlet syndrome, you'll notice that they have less, like their whole hand will go numb, where carpal tunnel will typically be only the first three fingers, thumb, index, middle finger, and then part of the ring finger. All right, one more undo. All right, and there it goes. All right, so let's hit the home button. All right, so now we're going to go through and we're going to discuss the different joints and ligaments that are in the area so you can kind of get how the joint looks. Now, as a preface to this section, when I'm down here, I can put one of the cool things about this. Okay, hang on. Rewind. Stop. Pause. Okay, play. All right. So this particular program. Sorry, I'm a little scatterbrained. This particular program has where you can start adding layers and start adding things to it. So that's what we're going to start doing now. Now, some of these I'll be looking and be like, okay, I want the fourth layer. That does not mean that it's the fourth layer of whatever tissue that we're talking about. It just means that is specific to this program. This is layer 4 on this part of the program. It may be layer 3 on a different part of the program, or it may be layer 6 on a different part of the program, just depending on what specifically we're looking at. The other thing is you will have some there are some instructors and some programs out there for massage that talk about the different layers of muscles. So like this is the superficial layer, this is the third layer, this is the fourth layer muscle group. And that is actually specific to them, their teaching style, their practice. It may be an anatomical thing, but it really has nothing to do with what we do with this program, because sometimes the fourth layer is not really the fourth layer down. It's just the fourth layer that this program has shown. So we're not discussing, like Eric Dalton says, the fourth layer back muscle. It's not the same as a fourth layer muscle on this program, although neither is wrong. It's just the program just does things in specific layers. All right, so we're going to start off here. And we're going to start over here with the sternoclavicular joint. Like I said, the sternoclavicular joint, this is the only joint that connects our arm to the body. And we're going to add in some ligaments until we get one right there. So that ligament is going to hold the clavicle onto the sternum and start to give some support to the arm. That is the only ligament that we have, is the sternoclavicular ligament there. Anterior sternoclavicular ligament. I wonder if there's a posterior. Is there a posterior one? Yep, there's a posterior one. So you have an anterior one and a posterior one. I will say I've never looked at that, but I also don't reach into people's necks like that. So it's not one that I'm super familiar with. All right, so we're going to take away these connective tissue and we're going to go down here to the shoulder and AC joint. So we have the shoulder joint and the AC joint. This here, this is a synovial membrane. This is going to be what produces the synovial fluid. Come on. Okay, there's my program. So this is going to be what produces the synovial fluid and help to keep that joint lubricated, because this arm does need to be able to do so many different actions. It does need to remain lubricated. Also, if something happens to the cartilage that is on the glenoid cavity or on the head of the humerus, we want to be able to have that synovial membrane is going to be what allows the nutrients that do get to it to get to that area, since there's not blood in a joint. So we are going to start adding in some ligaments. And now the ligaments that we add in here are going to start to become fairly important. Now, when you look at the shoulder girdle as a whole, the shoulder has some very powerful muscles holding this holding the humeral joint and the head of the humerus into the glenoid cavity. So it has the deltoid, we have the supraspinatus. All of this is holding the joint in. Those are very powerful muscles. So what we need is, we have a nice roof, we need a good foundation. And so that's when you get the inferior glenohumeral ligament here. The ones here on the anterior side, these are going to help give support to moving forward, to having that forward movement. So you have the inferior, the medial, and then the superior. All right, we're going to add in one more layer of muscle, or of ligaments, connective tissue. All right, so here you have the joint capsule. This is going to be the fibrous membrane that surrounds and creates the joint capsule of the shoulder. So you can kind of see how that works. And then you have the coracoid humeral ligament. So it goes from the humerus here and originates here at the base of the coracoid process. And so this really just gives a lot more support to that roof. Since we had the support on the bottom, we now need the support on the top. All right, now we're going to start to see some more of the ligaments and things up closer to the AC joint. This ligament here is going to help to create space in between and start to compartmentalize the shoulder girdle just a little bit. It also keeps muscles from popping, and it kind of holds things in place. Now, one thing I do want to mention here is we have this beautiful thing. This is a bursa. Now, this is our Coracloclavicular Bursa, so it's between the coracoid process and the clavicle. This bursa, a bursa is going to be a fluid-filled sac. It's filled with synovial fluid, and it's really there as a shock absorber. Because if we do have an injury to that AC joint, or if some sort of strain happens where the clavicle is depressed and the scapula is elevated, it will create deviation here in the joint, and what we don't want is this clavicle coming down and hitting this bone. So very small but still important bursa. Now we have other bursa as well. So we have more ligaments. They're covering everything, covering the AC joint, and then attaching the clavicle to the coracoid process there. And then we have some more bursa. Now, when people say have bursitis in the shoulder, a lot of times they're talking about this one up here, the subcutaneous acromial bursa. This is sitting right over that acromion. And then down here where we have the subacromial and the subdeltoid bursa. And a lot of times these are the ones that are become inflamed with bursitis. There's really nothing that we can do but time for bursitis. We can help to, if any of these ligaments or anything like that are damaged, the bursitis is there. We want to have the inflammation go down. This is something a doctor needs to recommend, and a doctor needs to say, hey, this is what we need to do. And so that needs to kind of be a doctor, but we can come in and then massage the muscles that surround it, because if there's injury to one of these things, the muscles are going to respond by guarding. So any of this tissue in here, that muscle is going to start guarding. Now, one thing I'm going to take 2 layers off. One thing I did want to mention is we have this thing here. This is called the transverse humeral ligament. Remember I said earlier we have muscles and we have muscles that go through here, and muscles that are around here. So this is actually keeping this tendon sheath kind of in place so it doesn't start popping off and away. So if you ever get on someone's shoulder and you're in this area and you can feel things and you feel like it's really popping underneath your hand, a lot of times that's going to be deltoid being very, very stringy, but you can sometimes feel that long head of the biceps right here. So I'm going to actually turn on some of the muscles so we can see that bicep and kind of how it goes. This is the other amazing thing. So here's the long head of the biceps brachii. So you see how it kind of goes into that tendon sheath. And if I remove all these ligaments and things here, we can see how it really floats in that space and then goes up and attaches over here onto the supraglenoid tubercle. All right, so let's add this. Well, actually, we don't need to add that stuff back in because I'm going to take it away here in just a second. All right, so that is the shoulder joint. A very, very intimidating joint, but it's one that's very commonly injured. And so really understanding the shoulder joint is going to be very, very important for any type of injury rehabilitation or anything like that, any work like that. So, all right. So no more muscles. We're going to move down to the elbow. So we have the elbow and we have the radial ulnar joint. Now the elbow only does 2 movements. It only does extension and flexion. So flexion is where the joint closes. So that's where the, it's like you're flexing your bicep. Extension is going to be how it looks right now. The rotation, pronation, supination actually comes here from that radial ulnar joint. So let's start to add in some layers because right now I have just the, there we go. So we're going to start here with just the bones and the joint. And let me move away, see if I can get that. There you go. All right, so that is the joint. We have the humerus up here. We have the ulna down here. It's on that medial side. We have the radius here, a little bit more lateral. First thing we add in is we add in that synovial membrane. But what I really want you to look at is I want you to look at that synovial membrane. We have, it surrounds the entire joint capsule. And then we have a couple very small but very significant ligaments. So you'll see a lot of collateral ligaments. When it's a collateral ligament, it's giving support. Just like when you get a loan, you want something to say, hey, I support this loan because I'm going to present some collateral. Here's my card. Here's, my business information. A lot of times collateral now is just your credit score. It says whether you're going to pay your bills or not. All right, so we have ulnar and we also have radial. A lot of these, again, you don't need to know the names of any of the ligaments. I'm not really going to be quizzing too much on the ligaments. You need to know that they do give support and that there are several. And the more movement a joint has, the more ligaments and more broad and more thick that you'll see those ligaments because there's going to need to be a little bit more support. All right, so let's continue. So we add in some more layers and then we start to see some more ligaments coming in. So here you have the fibrous capsule. The ligaments that are around here, you're going to see are fairly small, but that's because this joint only has open and closed movements, and much of the support that it gets is actually going to be from the muscles that are in this area because your biceps, triceps, brachialis are very, very strong. This is your quadrate ligament. It says because it looks like it has 4 sides. 1, 2, 3, 4. I think it has, I look at it and I see 3 sides, but I'm also living here in the 21st century, and I wasn't around when they were naming things, and I'm a girl, so I wouldn't have been allowed to give my information anyway. Here's a history lesson for you. Maybe I'll do a lesson on that as a bonus lesson. All right, so what we have here is we have our interosseous membrane. This is actually going to give support to the rotation, to this pronation, supination of the radius and ulna, but it really kind of supports them so they don't spread apart as we use them to do crazy things like push-ups. All right, and so now what we're going to do is we're going to remove these and we're going to go back to the wrist. Very, very, very small ligaments. This is a very small area. So when you have, just remember when we're thinking about this area, these ligaments are very, very teeny tiny. And we're going to start to see those ligaments and they're going to start to connect. Like every different bone is going to start to connect to the other bones. So you're going to see all these little ligaments that are kind of coming in through here. And so then we start to, as we add on more, you see the thumb actually in the wrist. You can see up here, up in between the bones, you see the interosseous membrane come in. But we start to see a thickening of the ligaments here on the thumb because this joint right here is a saddle joint and it is very, very hard to correct if an injury is in this area. It takes a long time for that injury to heal. So I'm going to take that away, and then we can see that how the ligaments are big and broad, and we can kind of push them on there. All right, so now we have the additional ligaments. Now, we're going to talk about this a little later on when we talk about injuries, but I want to kind of notate, like, wow, where did it go? What's going on? I'm trying to rotate it a little bit. There we go. Sorry. If I add the nervous system in, we have that nerve, and we see that nerve going straight down through that carpal tunnel. So you see how that carpal tunnel, it just kind of adds everything in. So all of these little things that look like little worms, these are all tendon sheaths. So these are all going to cover tendons. And then right in that center, right there is where you see that nerve that goes through. So if there's inflammation in any of these muscles that are going through here, see, I can even start to put the muscles on. So you can see how the muscles start to go through. If these muscles are strained, creating tendinitis at all, how that can then squeeze this nerve and then cause that carpal tunnel-like pain. On top of this one, this is the ulnar. So if you have anything, so you have that Guyon's tunnel right in here. See if I can, you can't really see it. There, you can see it a little bit right there. But you have the ulnar nerve, and this one is one that a lot of people also get where it really impinges and it hurts. So very, very important area. Just kind of quick right here, when they do surgery, they'll cut the underside of this. So they'll take a thing. They do it laparoscopically now. Then they have they cut here, and then they cut down here in the palm, and then they'll go in, and then they'll just cut a tiny thin area right here. So it's not going completely through this retinaculum here. Very important. Retinaculum keeps all of this stuff in line and where it's supposed to be. But if you have injury or anything to this wrist, this is where you start to get the carpal tunnel issues. They'll go in and they'll kind of cut this carpal tunnel. And not all the way through, they'll only cut a little bit into that retinaculum, which gives a little bit more space. The problem with having the surgery done is that once you have the surgery, you cannot correct it. So if the surgery didn't work, you will always be stuck with the scar tissue that's resulted from that surgery. Now, if they come to me and see me first to help to get these muscles stripped and to see if we can get this to where it's not really tight, I actually have a better way of manipulating those. Okay, I don't know what I'm saying. If they come see me first, I'm working with the muscles. nothing that I do is irreversible, but surgery is irreversible. I would rather them come see me before they go get surgery. That way, if what I'm doing doesn't work, then they can get the surgery. Because if they get the surgery first, I'm then trying to clean up, as they say, I have to deal, as the therapist, I have to deal with more scar tissue. The client has to work through a lot more scar tissue, muscle tension, and the guarding and the issues that come with having surgery. So I always tell people, it's like carpal tunnel surgery, see all of the things that you can do without surgery, see if you can do them first. All right. So that is the first part. So we have discussed the bones, we've discussed the joints. That is going to be the first part of this lesson. The next part of the lesson, we are going to be getting into the muscles, and we're going to be talking about very specific muscles with the shoulder joint, very specific muscles with the upper arm, then the lower arm, and then we're going to get into some of the conditions that are very typical that we see as massage therapists. So stick around and I'll see you next video.